Well, hello, everybody. Hi, my name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall. I'd like to welcome you all to today's live webinar, which is hosted by Roji Health Intelligence. This is actually the third in a three-part series titled How the CMS National Quality Strategy Can Guide You on Your Value-Based Care Journey. Today's session, which again is the third in the series, is called Maintaining Your Competitive Edge, How to Avoid Stagnation. And now, don't worry if you haven't been able to watch the other two. You'll be able to pick up, and we'll have links in when we send out a thank you email afterwards. There'll be a link to where you can go back and actually watch those other sessions if you would like. But I hope you enjoy today's session. I got a little sneak preview of it, and so I think you'll really take away a lot. A few items of note before we get started. This is a traditional webinar format. So you don't need to worry about muting your microphone or turning off your camera or anything. All that's been done for you. Um, but we do want to hear from you. We're going to have a time for some Q&A towards the end. And if you have a question at any point, go ahead and drop your question in you have a little module there that will have a place for questions specifically. So go ahead and drop your question in there, and we're going to get to as many as we can. If for some reason we don't get to yours or can't get to yours in the time allotted, don't worry, someone will reach out and answer your question via email afterwards. And finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email, maybe about an hour or so afterwards, that'll have a link to the recording to where you can download the slides, and you'll be able to share that with colleagues and friends or rewatch it at your own leisure, and we hope that you do. So without further ado, I would like to welcome today our presenter, Mr. Dave Halper, who is the Chief of Client Team with Roji Health. And take it away, Dave.
Thank you, Garrett. It's nice to be back for this third session. As you mentioned, this is the third of our three-part series. Earlier this month, we discussed, early in June, we discussed primary care, and then how the NQS and the CMMI models can bring you beyond the total cost of care is the only metric for a successful value-based care initiative. And then next, we talked about how to bring your specialists into the fold. And today we are going to talk about how to remain competitive once you've implemented everything that we've discussed in these last couple of webinars. How do you keep the momentum going? So a little about us, about Roji Health Intelligence. We're a value-based care strategy and technology company, and that means that we provide our clients the tools and the support that they need in order to measure and improve quality and cost metrics. Our tools highlight variations in care. We look at potential populations for targeted interventions based on a multitude of factors, and that's where things get very interesting, is because there's all sorts of different data sources out there, and they can all identify really unique ways that you can reach out to patients who are eligible for these targeted interventions. We've been a CMS qualified registry since 2008. That was the inaugural year that CMS opened the doors for qualified registries to submit data on providers' behalf for what at that time was PQRI, which later became PQRS, which then got merged into MIPS and also the APP, the alternate APM performance pathway for quality reporting. We are qualified to report on both CQMs, or excuse me, MIPS CQMs, ECQMs, and Medicare CQMs, and are in the midst of the self-nomination process right now for 2025, along with everybody else. So you are in the right virtual room, so to speak, if you are an ACO evaluating affordability and looking to enhance savings. You're also in the right spot if you're a medical group that's looking to maintain consistent revenue, or if you're an organization that is considering a value-based care initiative, something like population-based payments, capitation, anything along those lines, this is going to be important for you. And then finally, anyone who is negotiating contracts with risk features, whether you're a health system, medical group, ACO, these are all, this is going to be very useful for you. And here is why. We're going to be talking about the lessons that we have learned from our previous two shows. We're going to talk about how we are going to be able to continuously improve through focusing on cybersecurity and how it relates directly to value-based care. It's not peripheral direct relation. We're going to talk about how improving outcomes can be accomplished through transitioning to digital quality measures. They're on the horizon right now, but as we've seen with any CMS initiative, those who transition early are more successful when they actually become mandatory. And then finally, investing wisely. If something sounds too good to be true, you know the old adage that it probably is. So, before we get going, I'd like to take a brief poll here. Which of the following has really put the brakes on your value-based care journey momentum? Is it that the biggest savings that you have accomplished thus far can't be replicated? Is it that cybersecurity threats limit the resources for your IT staff? They're taking it away from things that are more directly related to value-based care and they're focused more on security. Choice C is clunky and burdensome to be performed effectively, or D, all of the above. This is a best answer, so I will turn it over to you all for voting. Interesting seeing these responses coming in. All right, it looks like we're coming to the end. Maybe a couple more, maybe a 10 count.
Yeah, yeah, I think so. Looks like most of the results have come in at this point. And by the way, this is anonymous, and so this is not going to be uh, shared, but you'll be able to. We will share you the results here shortly, and you'll be able to see where you stack among your colleagues. So I think most of the results have come in now, Dave. So I'm going to go ahead and
I
share
think
the
so.
results here. Right. Are you able to see it?
Yes, I am. It looks like we've got a tie. We've got quality measurement is burdensome and clunky, and then all of the above. And then following up is the biggest savings can't be replicated. All of these answers are great. I picked these questions deliberately because all of them, whatever you answered, I know that you're in the right place. So that's good. All right. I'm going to show my age briefly here and talk about how it is time to rewind. And we're going to cover some of the things that we looked at previously in the last two episodes to catch you up. So, first, a bit of a refresher. Over the last 10 years, the CMS Innovation Center has piloted dozens of models. Some have been much more successful than others. For the next 10 years, they plan to adjust program development to account for several key lessons. And I've got these lessons up here, and if any of you have had the opportunity to delve in to the fee schedule proposed rule that came out last week, you'll see a lot of these things that are making their presence known. I'll get more into that in just a second. But first, obviously, there's a very large push for addressing health equity and creating meaningful transformation using health equity. Also, models need to be simplified and complement each other when you have two programs that seem to be measuring um, efficiency and cost of care, but you're unsure who is attributed to which program. That obviously gets messy. Resources get thrown uh, um, in order for the programs to succeed. They have to complement each other and not to usurp one another. Um, all of the Innovation Center models have recognized that investment is required in order to succeed under risk. It's not something that you can do generally based on what you have starting from scratch. Also, financial benchmarks are very unclear. Selection bias didn't help. What I mean by selection bias is that since many of the models in CMMI were voluntary, the people who chose to participate in those models were doing so because they figured that they had a good enough chance to achieve some sort of savings. And The people who did not chose not to participate, and so obviously you get a little bit of selection bias. And then finally, top-down dictation eventually leads to backsliding, and that's not limited to innovation center models. That is everywhere. Um, the national quality strategy, the CMS national quality strategy, it started with the what they called the strategic refresh in 2021, and they further enhanced with quality in motion, which was an update in 2024. It's built on four key pillars. Each one of those has two components. Over the next two slides, I'll show you what each of those components are. Again, four goals, two areas of peace. High priority issues, as we can see in that first one, under outcomes, high priority issues are things where we know that there's an issue. It's something like maternal care. And then making sure that whatever you have, whatever you're measuring, is able to be benchmarked, it's statistically valid, etc. Alignment approaches across programs. There's some of that in the proposed rule, as is the Universal Measure Foundation. That's going to be what is behind CMS's transition from the APP to the APP Plus. More about equity and engagement, particularly input from patients and the community. I'll be talking about that a little more today. And then the last two goals, four components, are the safety and resiliency, and then interoperability and scientific advancement. Talk about some of those today, specifically the transparency and comparisons, and then the transition to digital quality measures, and I'll touch on AI here as well. The features that are prominent in every program, though, that we covered over the last two episodes are that there is an investment in infrastructure, enhanced data collection to identify disparities, looking at measuring quality across all patients, not just a set of patients. And that goes right into multi-payer alignment. We're looking to have one consistent, excellent standard of care rather than a sort of fragmented care that is already an issue. So these are the features that we see in every program. So as we strive to achieve these goals, the best thing for you to do as you're looking at them is how to maintain your momentum. And so to figure out how to maintain that momentum today, we're going to be looking at increased security, enhanced quality measurement, and informed investment strategies. So cybersecurity. Caveat, I'm not a security expert. However, I am an avid reader, and we all have seen these headlines come out from Ascension, where we could see the hack was traced to an honest mistake. An employee downloaded a malicious file. We saw here in Chicago at Lurie Children's Hospital that patients were unable to get care for parents were unable to get care for their children after that cyber attack. I know people personally who were affected by that, and then obviously the Change Healthcare attack made the Change Health attack is still making headlines. In fact, CMS just released within the last couple weeks a notice that they are finally going to be taking some resources back that were being used to help providers with that, and they're also putting up a new site that has some very helpful cybersecurity information for you. So when we're talking about cybersecurity, there's three key security protocols that all of us can focus on. The first is to address known vulnerabilities. The second is limiting access. Not everyone needs to have access to everything. And then finally, employee training. That is the big thing that was the issue for Ascension, is that clearly there had not been the appropriate amount of training. Actually, all of these apply to that. Access was not limited and known vulnerabilities were not identified. So let's start with those known vulnerabilities. The reason why it's important to know all of the hardware and software that's in use is because there are updates, maintenance windows, known issues that crop up that are specific to each piece. So having a set schedule globally is useful, but unless you know exactly what software is in use, what hardware you have, there's going to be a chance that something is going to slip through unless you are um, unless you have logged each one and know exactly what is due for service or patches, etc., and when. And that same thing goes for the antivirus protection. The next thing is multi-factor authentication for users. There's different options for that. There are, and what I mean by multi-factor authentication, a term, it's where you log into a site or an application and something else is required to confirm your identity. Maybe it's a text and you have to enter in the 6-digit code. Maybe there's something that is sent to your email and then you enter the code. Whatever the case, it ensures that the person who is logging into the application really is that person who is supposed to be logging into that application. Now, with all of that said, even the best laid plans of mice and men, there needs to be central incident planning and preparation. So if there is an issue down the road, everyone knows exactly what steps to take so that the issue does not build. And then finally, how to respond to all of those vulnerabilities. It is challenging though, because you need to balance productivity and security. As our system administrator likes to say, the most secure computer is a useless one because it is disconnected from the internet. You're not going to be particularly productive with that though. So the way to balance these things is by identifying a few key factors. The first is role-based access. So you should be limiting all of your users' access by responsibility. Does everybody need to have the same level of access? Absolutely not. So for some of you, that's going to mean that your IT infrastructure does not have any access to patient records. And the people who are looking at patient records should not necessarily have any access to the database that resides behind your EHR. It's all about understanding who needs what to accomplish their job, just like the just like in HIPAA, the minimum data necessary for you to perform what you need to perform. The next piece is having unique and up-to-date user credentials. When I say unique, I mean it is not secure to have an email or a username that is specific for your entire practice or a large set of you, because if somebody leaves, somebody joins, there's going to be a dissociated set of users who should have access and then those who do. And when I say up to date, that means that if you are managing your security protocols as employees join, as employees leave, how quickly are their credentials being added and removed? Because the last thing that you need is a window where there may be a bad actor who is leaving a position and still retains access. Um, Other things, and this applies the role-based access, that's the human version of it. There is also a computer version of it, a machine version, and that is network segmentation and firewalls. Should everything be able to talk to each other? Should whatever a single employee downloaded be able to create a huge security vulnerability that led to a network outage and ransomware? And then finally, don't forget about your vendor's access as well. It is amazing the things that we see in the field. Um, so here are some questions as you're looking at your vendors and what they are able to do and whether or not they are following these protocols as well. Can you grant role-based access to ensure that your private data remains private? So if you're looking at targeted populations for improvement with a clinical data registry like us, for example, do you have the ability to ensure that a provider can see that provider's practice as you add, but maybe another one? You have the ability to have a super group, subgroups, etc., to ensure that everyone is able to see exactly what they need and nothing that they shouldn't. And then finally, even in your vendor system, um, can you immediately remove a user's access? When I say immediately, I do mean that. or are you in a situation where you have to email that vendor and say, please remove so and so's access, and then you have to wait for that to occur? Like I said, that's one of those windows where a bad actor is still going to have access to your patient data and your private health and other private health information, and that is a huge gap in security. But if you are able to eliminate that account yourself immediately, that window is closed. Employee training is the third thing that I wanted to touch on. Ensuring that employees are trained on email and what can go wrong. So, what can be downloaded? Should anything ever be downloaded? Are your employees trained on phishing? Do they know not to provide password information? Do they know not to send passwords? Um, are they aware of social engineering? It is amazing um, what people are willing to post on social media and how easily that can be used to hack passwords. Also, identification of spoof websites and spam texts. If you are anything, if you have a phone like mine, every so often you will get a text saying, something needs to be paid. Click here to learn more, but it is absolutely not that. It's a random number, and do people understand that they're not supposed to do that? Again, same thing with spoof websites. Hackers have gotten very good at creating um, the imagery within an email to look like a trusted source. But if you look at the email behind it, you can see that that is actually not coming from it. But at the first glance, if you are not trained, it is very easy to think that you are being asked for something legitimate when in fact you are not. And then finally, the strong passwords, and this is real. The top 10 passwords of 2024, the old 1 2 3 4 5 6, and finally you can see that last note there about no sticky notes. It does not matter how well structured your password is. Does it have an uppercase, a lowercase, a number, and a non-alphanumeric character? If you've got it on a sticky note pasted to your monitor, it is suddenly not so secure a password anymore. So there needs to be a system in place for um, password resets, password updates as needed that does not entail passwords sitting right out in the open. So that's our brief take on some of the cybersecurity pitfalls that you can avoid by taking a few. Um, they seem basic, but it's, as we can see, they are not so basic steps to ensure that um, the data within your healthcare organization remains private. The next thing that we're going to do is we're going to talk about enhancing quality measurement. And the first thing that I'm going to talk about here is digital quality measures. Um, I don't like reading to you, but this is the definition. They are quality measures using standardized digital data from one or more sources collected without additional effort, and that's a big deal, and exchanged through interoperable systems. And that is the short version. I actually paraphrased that a little bit from the official definition. The fundamental issue with electronic clinical quality measures, the ECQMs we know and love now, is that first of all, they are only generated for patients who are eligible for a quality measure. And that makes them impossible to use in a broader population health context. So consider the APP. If you are an ACO, you're looking at three measures. You're looking at the screening for clinical depression and A1C poor control and blood pressure control. And yes, that touches a lot of patients, but it's impossible to use that narrow a cohort of patients in a broader population health context. Now, CMS is starting to address that by adding measures into the APP Plus, but it's still not nearly enough. And that is, in essence, the shortfall of ECQMs, is that it separates quality reporting from patient care, and it adds burden rather than reducing it. That is the goal with the digital quality measures that CMS is beginning to, I don't want to say they're beginning to roll them out, but they are taking steps to do so. And what they are going to do is they are going to um, update the underpinnings behind some of these EQMs. So right now we've got, if you've ever looked behind the scenes to the specifications for ECQMs, they are a mess. If you've ever tried to generate or process ECQMs, you know that it is also a very challenging task for both your IT staff and for the machines that they are running, because they are not automated by um, application programming interfaces. They are a very manual and very cumbersome effort to run. They're not called from multiple sources, which means that if you are taking them from one practice or another, you're going to get duplicative results that invalidate your quality measurement. And this one is the biggest, is that they do not utilize existing workflows. And so that is the situation that we see where you look at your results in an ECQM and you say, how am I getting performance not met for some of these measures when I have done the task and I've documented it? It's because whatever that the EHR is looking for when they pull that ECQM result, it's not in the space that they want it. So you may have done it, it may have been in the record, but it has not utilized the existing workflow that you have created for it, and so it's not plucked up. Digital quality measures are intended, or are going to be intended, to bridge that gap. And so how are they going to do that? They are going to do that, and you've probably heard this term before, FHIR stands for Fast Healthcare Interoperability Resources. And as I said, it's the goal of FHIR is to update the building blocks of the ECQMs as they transition to DQMs. It's going to facilitate accurate quality measurement, but it's also going to enable the type of bulk data exchange necessary for creating a strategic roadmap for cost control. We are not there yet in the proposed rule. This is called out. Right now, there is FHIR for many groups means a download of a single patient record, and within very short order, I'm sure you will all see that we will move beyond that, where it becomes usable for the sort of bulk data exchanges that are necessary for creating population health programs and truly understanding where there is variability in your costs and quality. Uh, Most importantly, in terms of from a physician standpoint, it is going to be aligned with your clinical decision support, meaning that when you put something in the EHR, you are going to get credit for it on the side, and it's going to reduce effort and lead time to implementing new measures as well, because you're going to be able to see much more quickly whether or not the steps that you are taking are fulfilling them, and if not, what can be done to address that. One of the other big pieces in enhancing quality measurement, and this was talked a lot about in the CMS National Quality Conference, is enhancing quality through patient engagement. So if you are more aware of topics like medication costs, transportation challenges, and physical symptoms, the treatment plans that you are putting into place with your patients are going to be much more effective than that sort of top-down approach. The patients are going to have the information that patients will have the information they need to make informed decisions, and they are going to be more likely to be active participants in their care, in their own care, because they feel that their voice is heard. When we're talking about uh, patient reported outcomes, these are the terms that we're looking at when we're talking about the patient voice. We're talking about pros, proms, and pro PMs. Um, Pros are patient reported outcomes. What are we actually measuring? Are we measuring, for example, is the patient telling you, are they in pain? Do they have fatigue? What do they feel is their functional status following a procedure? A PROM is a patient reported outcome measure, how it is being measured. And so are you using a certain scale? Are you using a specific index, etc. And then finally, the measure itself, how the proms are calculated. So are they reliable? Is the measurement something that can be tied to a single clinician? In other words, do you know it can be rolled up, but there needs to be some sort of accountability to understand where there is going to be variation in care. So if you're looking at, for example, pain post procedure, you're going to be able to tie that to um, the organization, but then drill down to potentially sites, providers, so that there is a valid level of attribution. The next step is investing wisely, right? We talked about how this is going to be a key component in any value-based care initiative in which you participate. There is going to be some upfront spending. Start early. Unfortunately, this actually is a picture right out of my library. A couple of Mother's Days ago, I waited until Mother's Day to buy my 5 Mother's Day cards for various sisters-in-law, mothers-in-law, and this is what I was left with, and it is perfect, the perfect picture to show here. I have since learned my lesson. There will be data-related obstacles. Comprehensive data that you will need in order to maintain your momentum to understand where everything is coming from. It requires education. It requires standardization. You need to be able to understand which practices within your organization are running which EHRs, which versions, what are they able to produce? Is there a roadblock? Is for example, is the developer sandbox up for that group right now, or is it down? So there are EHRs that have sandboxes where vendors are able to configure endpoints so that data can be transmitted and received seamlessly. If that's been down for 2 months, that's obviously going to be a problem. So these are the things that you will need to keep open in your mind. Also, once you do accomplish what you need to do in terms of data collection and data aggregation, early feedback is going to allow time for improvement, um, particularly in the quality reporting arena and when you're measuring costs. If you are if you are getting all of your information that you need for quality reporting just in the nick of time to send it to CMS or another private health plan, yes, you've accomplished the quality reporting goal and that you've submitted data, but you've cheated yourself because you have not given yourself the opportunity to see where there are issues and proactively address them. Remember that demonstrable improvement does take effort, and only action is going to drive the process. If it was easy, it would happen on its own. The next thing is to be prepared to customize. No two organizations are identical. You've got different populations. You've got different resources, whether they are technical, whether they are human resources, whether they are specialties within your network. Um, whether you've got differing organizational priorities, no two are equal. And so if you're trying to have a one size fits all approach, it's not going to work. Sure, there are going to be some pieces that work fine, but for something to work in real life, it has to really take into account who you are, what you currently have, what you are missing, and then how to bridge those gaps. It's got to perform in the real world. It's not enough um, to have something pretty project plan. In terms of investment down the road, also need to talk about what is on the horizon. And obviously, we couldn't talk about what's on the horizon in terms of investment without talking about artificial intelligence. I really like this illustration of artificial intelligence. It's a great pick of how once an observation is made, it then gets exponentially applied. And so you've got further and further learning that occurs and far-reaching conclusions. But here is the fundamental question right now for artificial intelligence and healthcare is how confident are you and your data integrity that you're willing to accept what's generated. Are you willing to take that first piece of information, first couple pieces of information, and see them deployed broadly? There is a lot that is still not ready. And so I want to make sure that that's clear. Now, with that said, there are a lot of AI opportunities in value-based healthcare. Patient risk assessment, cost control, improve outcomes, patient engagement and communications. These are all tools that are going to be ripe for AI build out. Um, and we've already seen some of them. The intent is to support clinicians with AI. It's not to replace them. And so far, we've seen just recently uh, extremely pathology-based predictions of mortality, improved accuracy in colonoscopy screenings, new drugs for neurodegenerative diseases, and enhanced risk assessment for patients. Who are the patients that are going to be the ones that are incurring um, high cost services, et cetera? And so it's fantastic to see where we're going. But with that said, there are AI limitations right now. It is not a catch-all solution. So as you're investing, do not feel that a solution in AI is your one-stop shop because the data is still messy. If it wasn't, we'd all be interoperable as we speak. There would be no need for a push for fire. So as you are looking at AI right now, remember that the way AI works is that something is seen, recognized, and then there is a sort of a neural build out based on those initial observations. And so if there is data that is incorrect, inaccurate, and we know there is because we all saw what we see that with ECQMs, we know that it is not something that is going to be able to to work down the road. Finally, all AI models are local. It is impossible to avoid bias when everything is local. There isn't a large enough subset of patients, providers that are involved in it. And so there's uncertainty in how these models are going to be created and how they produce results. It's that same level of opaqueness that is causing such frustration when you're looking at cost benchmarks, for example. If you can't see how the AI was able to derive the conclusions that it achieved, it is not going to be something that gets any sort of buy-in because it's not going to be trusted. Now, there are some core principles for responsible AI. Excuse me here. Got my battery notice. There we go. Some core principles for responsible AI. This came from the CMS National Quality Conference. From a group called the Coalition of Health AI. And you can see them all here, but the one I wanted to flag right now first is usefulness. When I say usefulness, what that means is that it is valid. Is it statistically accurate? Is it beneficial and effective? Um, is there some use for it, or is it simply just there to be there? Can it be tested? Is it something where you can determine whether or not it is working correctly? And then is it robust, or is it something that is so that it really doesn't have any broad context? And is it usable? Can people use it? So these are the core principles for responsible AI. So as you are looking at investing in AI, keep these in mind as things that are going to need to be a part of your program. All right, so let us wrap it up. We've got a few keys here that I want to go over with you and for improving over time. The first one is a heavy dose of realism. The low-hanging fruit approach works once. If you have identified which skilled nursing facilities keep your patients for the full 30 days and which ones are more aggressive in having them meet discharge goals based on functional status rather than time, that is, first of all, that's fantastic. Good for you. But the issue there is obviously once you've done that, yes, you have generated a full set, you've generated a lot of savings, but you have not done something that you are able to replicate and continue to build from. Ideally, you'd be able to use that same sort of methodology in building, let's say, a narrow network, but that's going to be more challenging, and it does involve that heavy dose of realism. The low-hanging fruit approach works once. Next, we want to have a quantifiable target. There is saying that you want to improve quality. That's not a that's sure, that's an admirable goal, but that doesn't cut it in terms of being able to set a goal and then have a milestone step-by-step based action plan to get to that. And so here is what I'm talking about. We want to first establish a goal and then a specific goal as referenced. Define your success criteria. So let's say you're looking at um, you want to have improved surgical outcomes. Okay, great. Does that mean fewer readmissions? Does it mean fewer surgical site infections? Does it mean patients are reporting lower pain scores 2 weeks following the procedure? So it's like I said, it should be a specific goal, and there should be very specific success criteria to go along with it. Once you've defined that success criteria, you have to figure out a plan and an implementation plan. Once all of that is done and you implement your plan, the question is, did you succeed? Well, it's not it's much more of a black and white answer now because you have defined specific success criteria to know whether or not you've accomplished your goal. There's nothing to debate. If you did not succeed, that is not necessarily a bad thing. It could be that the goal was too optimistic. You may have improved, but you didn't accomplish your goal, but that doesn't mean that all hope is lost. Um, it's important to examine then the root causes of the reason for the goal not being accomplished. Is it happenstance? Is it fault? Remember, this is a long-term improvement process, and rather than trying to necessarily find fault, we want to see the root cause for it and understand why it was not accomplished. It could be something very basic. An example that I've used in our previous slideshows is when we were looking at an organization that had higher blood pressures among some of their most prolific primary care doctors. Upon looking at the results, it had nothing to do with hypertension management. It was that blood pressures, the new nursing staff that had been brought on had not been trained on the proper way to take blood pressures, and so patients didn't have both feet on the ground, did not have their back supported, etc. And so the results for blood pressure were overly inflated. And so yes, they did not accomplish their goal at first, but they learned an important lesson and then were able to swing back and redefine their success criteria, plan, and implement. On the other side of the coin, if you did succeed, ask yourself, really, was the goal too easy? That's possible too. If it was too easy, it's time to establish some new success criteria for that goal, because true improvement is not going to come by setting extremely easy goals that don't actually reflect any improvement in quality. If the goal wasn't too easy, you have made great steps. Wonderful. Is the goal maxed out? Have we taken it as far as we can? If yes, ensure that that's positive change persists to avoid backsliding. If not, establish new success criteria. And at the end, no matter what, repeat. There's always going to be something that you can improve upon. And so this is your flow chart for doing that. That takes me to questions.
Uh, all right. So we do have some audience questions that have come in, and I know there's a lot there for everyone to chew on. So if you have a question right now that you would like to ask Dave, go ahead and drop that into the your module there. There's a place specifically for questions, and we'll get to as many as we can today. And if someone or if we don't get to yours for some reason, someone will reach out via email to answer it. But in no particular order, um, how about this one? How does the 2025 physician fee schedule proposed rule relate to the points in this presentation?
You are asking the right person because I have spent the last several days poring over that in great detail. We're actually going to be having a blog on it very shortly. I encourage everybody to check that out. To answer the question, I would say the introduction of prepaid shared savings is a really good example of that. So we're talking about a recognition that there does need to be early investment, and so there is a provision in that proposed fee schedule final rule that for ACOs and two-sided risk models that have consistently generated shared savings, you can get an advance on future savings and use half of that on infrastructure. And within that infrastructure, that includes um, clinical data registries that can aggregate disparate data sources and identify patients for these targeted interventions, and also will help you identify where there's variations in cost and outcomes. So definitely tie in from the proposed rule into that early investment and the being able to invest in that healthcare infrastructure.
Great. Next question is patient-reported outcome measures aren't part of the APP or even the proposed APP Plus. Why should an ACO utilize them?
That's a good question. I like that. It goes back to my previous statement about the difference between quality reporting and um, and increasing the health of your population as a whole, and shouldn't be a barrier into that. And it sort of highlights the issue that I described with reliance on ECQMs. There's a lot that it can impact costs. There are measures right now. There are patient-reported outcome measures on a variety of things. There are things like functional status following a procedure, for example. They can help you illustrate variations in care that can be proactively addressed. Um, they can highlight gaps in communication between patients and provider, especially the ones that are related to pain post procedure. So if the provider and the patient are talking in a before a procedure, and there is a greater understanding about what to expect following a procedure, there's going to be less likelihood that the patient feels that what they are feeling is out of the ordinary and would necessitate a trip to the emergency department, for example. If there has been a clear shared decision making conversation held with provider and patient and care team, that is going to save. It's going to be great for the patient reported outcome measure. It's also going to save money down the line because it is going to reduce um, unneeded trips to the emergency department.
Yeah, very good. Next question is, are there some good tools for evaluating the integrity of data?
Evaluating the integrity of data that is very broad, and I would say the first is basically running your reports and seeing whether or not they are true and accurate. So if you're running reports from a vendor, do they look like what you see in your EHR? If you're running them directly through your EHR, are they what they see in your patient record? So that's the first step, I would say, is to just look at the results that you're getting and see if they can that they are accurate. Do your providers, when they look at their results, do they feel that they are accurate, or do they feel like something is missed? And then you need to be able to walk whatever those results are back to an individual patient. That's why QRDA 3s are not our favorites here, is because there is no ability to validate whether or not they are true, accurate, and complete, because you can't tell which patients are accounting for which results.
Very good, very good. Well, that actually wraps up the questions that we have for today. So we're ending a little bit early, but no one's ever complained about a webinar ending early. So, but thank you so much, Dave. This was a fantastic presentation. Obviously, there's a lot there. We're going to be sending out the slides and a link to the recording where you can see that and you can go over it again. And of course, if you have any other questions, feel free to reach out to us and we'll answer those or to Dave specifically. If you can reach out to me and I'll pass that along to Dave. But as we close out here, I'd love to encourage you all to head over to vbcexhibithall.com. And when you get there, you'll see that Roji Health Intelligence has a virtual booth there. And there's a lot of really great resources. You can read it on them and what they're doing in space and really educate yourself on them. And of course, there's ways to contact them through there, and feel free to reach out to me as well if that's easier, and I'm happy to facilitate an introduction. And finally, if you would like to reach out to them directly, though, their contact information is right here on the screen. Dave is of course our presenter today, and Leonard would be, he's in sales, he'd be willing to or more than happy to help you out there. Or again, feel free to reach out to me. I've known these guys for a long time and can really vouch that they're a wonderful organization and you're in good hands with them. So thank you all so much again for joining us for this three-part series. Again, we're going to be sending out a link to the recording soon where you can also get the slides, and a link to part 1 and 2 where you'll be able to watch those as well. So thank you all so much for attending. Hope you have a wonderful rest of your week. Bye-bye.
Thank you, everybody.